thanks for the privilege of being here. I like to give you as a good morning topic an overview about the virtues of the 5-aminosalicylate therapy in ulcerative colitis. And I'm going to touch some areas of recent development, so you see it's not that kind of a dead and old topic, but also bears some potential for innovation. So ulcerative colitis is the domain for 5-aminosalicylate therapy. In the European population, we have a prevalence of up to 0.2, 0.3% in our population. This means that there are several millions of patients with ulcerative colitis out there. And you see that the disease is not that kind of easy as people think, as there is a high relapse rate in the first year after diagnosis, and that a considerable number of patients develops a periodic and chronic course with frequent relapses. There is substantial differences between ulcerative colitis and Crohn's disease that may explain also the differential activity of the aminosalicylates, and the most important one may be that the disease in ulcerative colitis is more mucosal and a little bit submucosal, not transmural as in Crohn's disease. The presentation of the disease is in some cases in pancolitis, in most cases in left-sided or subtotal colitis, eventually then progressing to pancolitis, with the exception of children, where we see much more pancolitis on initial presentation, and where also I think 5-aminosalicylate are less likely to work. The real challenge comes from this data here from Copenhagen country in Denmark, where they have analyzed over 25 years how patients do with ulcerative colitis. And you see that there is about half of the population in remission, but the other half is not doing so well. They're either active or they already have undergone colectomy, a definite procedure to cure the disease. So there is obviously some need, I think, of intensifying therapy and thinking about consequently treating the patients. In ulcerative colitis, we have learned very early, already in the textbooks I learned, that mucosal healing is an important goal. This has been underscored by population studies like the Ibsen trial, in which everybody in South Norway who had developed inflammatory bowel disease within a year, about 10, 11 years ago, was registered and then followed. And you do see that the mucosal healing in ulcerative colitis, for example, gives a big difference between those patients who undergo colectomy then later in their life. These are the ones who do not show mucosal healing during the first years. These are the ones who show mucosal healing. So mucosal healing becomes an important and own therapeutic goal which can be reached with 5-aminosalicylates and which should be also part of the therapeutic management of the patient, especially if you consider that mucosal healing assessment in ulcerative colitis just requires a proctosigmoidoscopy and not often a full colonoscopy. This becomes important because you try to avoid end stages like this here. This is a patient with ulcerative colitis who obviously no longer has any inflammation, but I think you can imagine that this colon does not work anymore, and this patient will be never symptom-free. The only way you can cure this patient, help this patient now, is a colectomy, and I think we should avoid the mucosa transforming from this into this. So I think it becomes very important to treat the patients adequately. So the current goals are managing symptoms and induce remission, maintain remission, and obviously, as I lined out, endoscopic remission. What else do we want? Obviously, we want to be more rapid in the control of symptoms. 5-ASA, as we know, is a slow-acting drug. We would like to maintain our patients off steroids. We want to give them normal quality of life. We want to create lifelong perspectives of patients, and we want to avoid permanent mucosal damage and cancer. So we want to change the natural history of disease. For this, I think it has to be importantly considered that 5-aminosalicylate is just the start, I think, of development which goes much further now and which gives us many, many more options to choose if this doesn't work. So when I speak now, I speak about the baseline therapy which every patient should get early on in the disease and probably which should be continued throughout the disease management. Aminosalicylates are delivered for mucosal treatment. And there are different ways how to deliver this drug. It's an anti-inflammatory compound which has similarities to aspirin, but is modified from aspirin, so it is not the same and has fundamentally different activities. And there are different ways how to get the molecule into the bowel and to make sure that it's not absorbed, but it acts on the inside, on the inflamed mucosa. One of that is to create a double molecule, either by putting the 5-ASA molecule on a carrier and introducing a so-called diazoband. It's a big molecule that cannot be taken up in the stomach, but when it sees the terminal ileum and the bacteria there, they will split the diazoband here and then release the 5-ASA from the double molecule. And such double molecules are the historic molecule with everything started, sulfasalazine, where sulfonamide has been coupled to 5-ASA, and later carrier molecules like balsalicide or two 5-ASA molecules linked to each other like olsalicide. And then there are physical ideas on how to slow down release and make sure that you pass the stomach and the small bowel, either by putting a pH-dependent coating over it, so-called Udragit resin, which either gives a pH of 6 or 7, creates a barrier that only dissolves at a pH of 6 or 7. So it doesn't dissolve in the acidic stomach or doesn't dissolve in the small bowel. Only when the pH goes to 6 or 7 in the large bowel, it will open, or to micropellet the 5-ASA for slow release throughout the small bowel. And these are the release profiles. You see here that the different forms here release quite differently. This is the micropelleted form, the slow release like pentazan. These are the Udragit coated forms. Here's the stomach and here's the rectum. You also see a challenge here. And the challenge here is that enough substance should go to the rectum to make sure that there's still enough drug available to treat the mucosa. So sulfasalazine, as the historic carrier molecule between the sulfonamide and 5-ASA, has been the mainstay of treatment for almost 2 decades after the Second World War. And as you see here, small trials were already sufficient at this time to establish the activity of sulfasalazine against placebo. And I think this has been thoroughly done in a number of studies, and then it has been used, I think, in probably 1 million of patients. Oral mesalazine has then been introduced to replace this compound. And the reason was that the carrier molecule, the sulfonamide, gave a lot of side effects when you dosed the drug highly. And these are, again, small studies, which at that time were sufficient, that could establish that mesalazine in a dose between 1.6 and 4.8 gram a day is active in ulcerative colitis. Later trials then compared the already introduced drug sulfasalazine against mesalazine, against the pure 5-ASA compounds, and looked here at so-called meta-analysis. Everything on the left side would show that there would be a weakness of 5-ASA compared to the standard sulfasalazine, and everything on the right side would show an advantage. And if you look at the end of all these studies, you find an equivalence between the new 5-ASA compounds and the old sulfasalazine. A maintenance of remission, pretty similar picture. Again, sulfasalazine at that time introduced into the treatment of ulcerative colitis, and you see here that the meta-analysis show that there is quite an equivalence between the new 5-ASA compounds and the historic sulfasalazine. How about doses? We do know not much about doses because most of our data is historic. We do know that there is effectivity starting from a dose of 1.5 grams a day. During induction of remission, there is dose dependency, and you see that a dose of 3 grams is more effective than a dose of 2 and 1.5 grams. So this is the standard dose for active treatment, and in some cases this is dosed up in some jurisdictions up to 9 grams a day. This is the United States and Germany. Some practitioners go up to 4.5 grams per day when they treat active disease. The data only shows a dose dependency up to 3 grams per day. It has not been followed any further. In maintenance of remission, There's really no good dose-finding study. We know very little. We know that less than 1 gram a day appears to be the same as 1 gram a day. The usual dose, which is applied at the moment, is 1.5 gram a day. It should be pointed out that 5-ASA is highly effective also when given rectally. As a topical drug that acts directly on the mucosa, you can apply it into the rectum, either in the form of suppositories or enemas. And this is still, even if patients don't like it, a mainstay of therapy, because most of the symptoms the patients will have come from the last 30 centimeters. So to induce preferential healing in that region, I think gives the patients a large deal of benefit. And so I would encourage everyone, at least in the active part of the disease, to also apply rectal topical therapy. And this, as you see here in these studies, is also highly effective. And even more, if you compare 5-ASA enemas with the high dose of 5-ASA on the mucosa against corticosteroid enemas, where everyone would think corticosteroids is probably a more active drug, you find a definite advantage of 5-ASA over corticosteroid enemas. In these studies, in every one of these, 5-ASA performed better, although not always significantly better, than corticosteroids as an enema. And you see here in the meta-analysis a definite advantage of 5-ASA being twice as strong as corticosteroid enemas. So if you use enema treatment or suppository treatment, 5-ASA is the drug of choice. We do know that 5-ASA has also been studied for remission maintenance in Crohn's disease. Only one formulation, I think, can be considered there. It's the pent-ASA formulation that shows a slow release, which already sets 5-ASA free in the small bowel. And here you see a meta-analysis that shows a very, very, very small efficacy in Crohn's disease. The most recent trials have been negative. At the moment, it's not recommended for Crohn's disease. In Germany, it's still used in about 20% of Crohn's disease patients, just to offer some form of therapy to the patients, but we really should not consider this as effective treatment, not even for mild disease. It is not proven. You see here the very small signal if you put all the studies together. It is different in remission maintenance after operations, and we already touched this yesterday by one of the speakers pointing out that the number needed to treat is about 15, which means you have to treat 15 patients to have the benefit in one patient. And this is what also the meta-analysis shows. There is activity, but it's very weak, and if you want to maintain remission after surgery in Crohn's disease, there are other drugs that are more powerful. So what happens if 5-ASA fails? I think the present use of mesalazine therapy still has its limitations, obviously. There's incomplete success. There's end-of-dose relationship that's not clear for most of the formulation. Simple pH or time-dependent release principles may suffer from differences between healthy volunteers and patients. I mean, the idea is how the drug should be opened with a pH change or with time does not always work in patients. And then finally, if you have to step up to glucocorticoids, then this is a worse prognostic factor in patients. So optimizing 5-ASA therapy and preventing glucocorticoid induction is a big independent goal. And that there could be effectivity which could be boosted is shown by the enema treatment, where 5-ASA beats glucocorticoids. So one has to think about, can we come up with other solutions? And this here, for example, a colonoscopy, where you find the granules here in the terminal ileum. Or can you avoid problems like this here, where you see non-adherence patients in large numbers occurring, about 40% of the patients being not adherent to 5-ASA therapy. And this is leading to relapse and probably being the most single important cause of relapse in ulcerative colitis, that patients don't like to take 3 times a day 5-ASA. And non-adherence is a problem during maintenance therapy, and you see that here, for example, for the hospitalization rates that are clearly up in all of these individuals being non-adherent. So there has been innovation in the 5-ASA formulations, and the idea here was to optimize delivery of active drug using a novel technology, then to demonstrate obviously the benefits also on patient response, and to simplify the dosage regimen to make sure that the patient is taking less drugs. The idea here was to pack 5-ASA at a much higher dose into tablets, so to have much more than 0.5 gram, to pack up to 1.4 gram of 5-ASA into a single tablet, and then also to create a different release mechanism, making sure that the release is more evenly in the colon. You see here the release profiles of 5-ASA MMX, which was this new formulation, which was introduced a few years ago, obviously very coherent between different experiments. These are release profiles of ASA different tablets, and you see here that obviously there's a certain spread of release and it's less reproducible. And then the second goal was to come away from taking so many tablets and obviously coming into an easier solution of taking much less. These tablets now contain 1.2 grams of 5-ASA per tablet. The primary endpoint in that study was response and remission. Remission was measured here in this slide, and you see their new formulation, which is also called Mesavant, 2.4 gram given once daily, 4.8 gram given once daily. You see a reference arm here with Asacol, and you see placebo, and you see that there is efficacy, obviously, if you give 5-ASA only once a day. 2 tablets, 2.4 gram are sufficient. You do not need to have 4 tablets, only in the morning, and this beats placebo. This is also, although that wasn't specified, obviously better than Asacol. And I can tell you also why it is better. It's not better because this is a different drug, and I'll show you the slide later. It is because patients tend to take their morning dose much more frequently and much more consistently than their lunch or evening dose, where they forget or do not want to take the dose. Mucosa healing, similar picture, at the 2.4, the 4.8 gram per group once daily, Asacol and placebo. In the post-hoc analysis, we learned one important thing. We learned the time to cessation of symptoms, because this is one of the few modern trials where these things have been measured. And we do know now that the median time to cessation of symptoms, which we can expect, should be 7 to 8 days to the cessation of bleeding. It should be about 25 days as the stool frequency normalizes, and both after about 3 to 4 weeks. So that's about the time you should give a 5-ASA therapy before you see the first activity of the drug working. Adverse events, also not very well measured in these historic studies, are now measured with the precision of modern trials. And you see that the 5-ASA, as expected, is very mild in adverse events, some headaches, some flatulence, some abdominal pain, nausea. These are the main problems. Occasionally you see allergic reactions like kidney inflammation that can lead all the way to acute kidney toxicity and acute kidney failure. This is dose independent, and the same about amylase increases and occasional pancreatitis, which both should prompt you to stop the drug immediately and not reintroduce it in this patient. Now, is this so special about this new formulation, or is it the once daily dosing which makes the difference? And so the makers of another compound, of Pentasa, have asked themselves the question and tested what would happen if you take one of these historic formulations once daily rather than split the dose. And to a big surprise, or not a big surprise, you see that the 2 gram once daily here beats also the 1 gram twice daily for Pentasa. So obviously to give all the 5-ASA in the morning is a big benefit for your patient and leads to better adherence and therefore better therapeutic efficacy. So finally, there has been a comparison to enemas. Do we still need enemas? And this is only a small study. The Rachmaninoff index has been used to measure efficacy. It's a composite index between also mucosal inflammation and obviously a number of symptoms, including fever and general inflammation symptoms. And when this was done, it showed that the high dose 5-ASA MMX, 3.6 grams per day, so 3 tablets, was almost as good as the enema, or as good as the enema. So if you give these modern drugs at high doses, you may be able to even spare some of the enema treatment.
Professor Scheriber, you have 2 minutes.
Oh, good, wonderful. Finally, cancer risk. I like to point out that there is inflammation as a driver for cancer, as you see here in this analysis. Long-standing inflammation gives a problem with increased cancer risks. There is a weak effectivity of 5-ASA treatment on cancer. It is not clear whether this comes from a better medical treatment, because it also is confounded by more doctor's visits and by a more intense management of disease. But I think it's quite clear that obviously managing your patient well, including 5-ASA, brings down cancer rates. So I like to conclude. The future of mesalazine therapy is still ahead of us, so it's not a therapy which should be laid off. It's an important mainstay of the therapy of ulcerative colitis. I think the optimized use with focus on mucosal healing can drive higher success rates and avoid escalation to glucocorticoids in further steps. And I think this should be one of our goals. The baseline medication with 5-ASA in UC is associated with carcinoma prevention. In uncomplicated Crohn's colitis, it is unclear. Maybe that newer formulations change our picture here in the future, but certainly at the moment is rather weak in its activity. 5-ASA is used by practitioners in other forms of chronic inflammation, diverticulitis, post-inflammatory IBS. There's hardly any data out there. In diverticulitis, there's even a negative study, which, however, may have been over-engineered. And colonic adenocarcinoma prevention properties are at the moment discussed. There are trials from time to time, discussed but never done, where low-dose 5-ASA should be used in the general population to prevent colonic carcinoma. But I think this is a future outlook which first has to be proven. Thank you very much.
Thank you, Professor Scheriber.
Our next speaker is Professor Richard Fedorak from University of Alberta, Edmonton, Canada. He will continue his valuable lectures from yesterday, and he will speak about current management of severe and refractory ulcerative colitis. So, Professor.
Good morning, everyone.
20 minutes.
So yesterday I had rules for you in my talk, and today I'm also going to have rules, but I'm going to combine it with a case. With each section of the case, we'll talk about evidence-based medicine to support the management of that case. So this is medical therapy for severe ulcerative colitis. You've just heard from Dr. Stephan Scheriber about the management of less severe colitis, that mild to moderate, that responds well to 5-ASA, and not to remind ourselves that 5-ASA continues to be the mainstay of ulcerative colitis treatment. All right, this is the case. You referred a 26-year-old male into your clinic. He has a 1-year history of pancolitis, so it's both endoscopically and histologically confirmed. He had been on mesalamine 4 grams per day as maintenance therapy. He'd also been put on oral prednisone for about 12 weeks, but had been unable to taper below 15 milligrams. It was said that azathioprine caused pancreatitis, but in checking that, that was not true. Now, the last 2 weeks, he comes to see you, and here's what he says. I have diarrhea 10 to 15 times per day, 100% of the bowel motions with blood. I have some nighttime fever, and then you do some blood tests, and his hemoglobin is 85, and the C-reactive protein 52. And he also tells you the diarrhea has severely affected his life, and he's not happy. So you move to evidence-based medicine, and you begin to think, what should be the expected response to someone who was on steroids, outpatient steroids? This study from a long time ago, in the 1960s, would tell us that in green, 80% of people should have responded to that regime. Some 5-ASA, some prednisone. Most people are going to get better. He falls into this small category of red, where 20% of people will fail tapering of prednisone, fail that course of prednisone. So that's what we know from the evidence-based medicine. So you're dealing with a small category of patients here, perhaps 20% in your office. You also want to think, as you look at this gentleman, what category of ulcerative colitis does he have? Because this category is going to direct your treatment. Is it mild? Diarrhea less than 4 times per day, no fever, no tachycardia, no anemia, CRP is low. Nope, he doesn't have mild disease. In fact, he has severe disease. And this comes from True Love and Wit, the Oxford criteria, the 1950s, before most of us were born. Bloody diarrhea, greater than 6 times per day, fever, tachycardia, anemia, high CRP. That is severe colitis. That is severe colitis because those are the patients that ended up going on to colectomy. And little has changed in the last 40 years. People with those symptoms have a high risk of colectomy. So you have a man with severe ulcerative colitis who's in your office. The question for you is, what would you do with this man failing outpatient corticosteroids? Are you going to treat him again? Are you going to up his prednisone? Are you going to put him on Imuran? Are you going to do what? Think. So this is what I did. This is what I would do. I admit all these people to the hospital. You have severe ulcerative colitis. You can't come off your prednisone. You have an elevated CRP, 100% blood, more than 6 to 8 bowel motions per day. You're coming into hospital. I'm not going to be able to manage you appropriately as an outpatient. Same day, unprepped colonoscopy. I don't prep these people. They're having enough diarrhea, enough blood. They're going to be clean enough. I don't need to see every single detail. I'm not looking for dysplasia. I'm not looking for cancer necessarily. I'm looking for disease severity. I'm looking for the extent of the disease. I'm getting cultures for C. difficile in the suction trap, and I'm doing biopsies for CMV. I don't put a lot of air in, and I just go as far as possible. If I can just get to the transverse colon, hepatic flexure, and I can't go much further, that's enough. I have my answers. So evidence-based medicine. So now you're thinking about treatment. You got him in hospital, you've done your colonoscopy, severe deep ulceration, it's bleeding, you've taken biopsies and C. diff cultures. What is your treatment? So I've tried to summarize your options here. Evidence-based medicine, EBM, evidence-based medicine. Do you use steroids or infliximab on admission? I take a number of these studies, particularly the one from Paul Rutgers and Simon Travis, and I looked at outcomes. Steroid-dependent refractory disease, whether you go on infliximab treatment or the standard methylprednisolone. And really, in my mind, my reading of this, the outcomes are about the same. 20% colectomy rate no matter which group of patients you're in. So my key take-home message from this is I like to use prednisone as that first therapy. I'm going to get a rapid response. It's tried. It's true. And if I can get them well on this prednisone, I'm not necessarily left to having them on lifelong infliximab. So key take-home point, treatment of choice in someone failing corticosteroids with severe ulcerative colitis, methylprednisolone, milligram per kilogram, 1 to 2 weeks, and then tapered off. Okay. So that's the evidence. Admit this man, do a colonoscopy, now put him on intravenous corticosteroids. What else would you do? Rectal therapy. We heard from Dr. Scheriber, 5 ASA. How long do you leave him in hospital? Aha. Something is not happy. So here's what I did. These are my rules. More rules. He gets methylprednisolone 40 milligrams every 12 hours. Continuous infusion or twice daily get the same efficacy. So I make it easy. They get it every 12 hours. I put him on ciprofloxacin. And this is empiric. He's got a fever. Like blood culture, but he goes on Cipro. He also goes on metronidazole, maybe vancomycin, pending my C. diff toxin assay. In our hospital, 60% of people will have C. diff toxin positive. We have a real problem with C. diff. I'm not sure what you have here, but think about it. I also put them on mesalamine, maybe not that first couple of days, but they get it relatively early. I know it's not synergistic, but I want them to go home on it. I want them to become familiar with those pills. Like Stephan Scheriber said, I use rectal therapy. In this case, I would use a corticosteroid foam. It's easier to keep in than the enema. You heal that rectal reservoir. You get less symptoms. That's an important adjunct. They're on clear fluids for 3 days. It prepares them for surgery. If this case is going to surgery, I've got them on clear fluids. It also helps with some of their symptoms. They get daily diagnostics. At a minimum, albumin, electrolytes, creatinine, you can see the list there. Abdominal x-ray looking for toxic megacolon. Number 11, rule 11, most important, stool chart at the bedside. I only care about their numbers. I want to know how many bowel motions per day and what percentage with blood. And the patient marks that down, not the nurse, because the nurses will always forget. Patient's responsibility. It's on those numbers that I'm going to make all of my next decisions. And you have great colorectal surgeons here, involve them, because this case could end up in surgery. All right, evidence-based medicine. How long do you wait before you say the IV steroids have failed? Again, this is all work from Oxford over the years and other places, but 3 to 5 days, critical assessment level, key take-home point. If there's no improvement by 3 days, you're talking surgery or some other rescue therapy. And you can see the numbers there, 80% predictive value for colectomy if you have any of those 8 bowel motions per day or high CRP. So by day 3, they need to be getting better. If they're better by day 3, I know that I can go to day 7 to 10 without increase in mortality. And if they're better by day 7 to 10, I know from the literature I can keep going. So those are my milestones. And the stool chart is what I follow. Number of bowel motions per day and percentage with blood. It has to be going down every day. It never fails. So how do you determine steroid failure? So that stool chart at the bedside, as I said, rule number 12 again. Day 3, failure is not any improvement in number of bowel motions and not any improvement in blood, and you're advancing to colectomy or infliximab, some biologic therapy. And if there's success, you're going to persist, because I said you can, success at 3 days means you can go to 7, 7 means you can go to 10, 10 means you can go to 21. But number 13 here, my man was failing IV steroid therapy. He wasn't getting better, and he's refusing colectomy. Absolutely not doing colectomy. So what do I have? Evidence-based medicine. There's a couple of things you can do. Let's focus on cyclosporin. It's been around a long time. Here's the evidence for cyclosporin. First bullet, cyclosporin alone. There's probably more now. 22 randomized controlled trials, 4 were controlled, 18 uncontrolled. 2 milligrams is equal to 4 milligrams, so you want to use the 2 milligram. But these are short-term responses on cyclosporin, 50% colectomy at a year. So there's other trials, cyclosporin, and then they go home on oral cyclosporin. 25% colectomy at 1 year, so that's better. Longer treatment is better. Bottom bullet, IV cyclosporin, then oral cyclosporin for 3 months, and then azathioprine. So now you're using long-term maintenance therapy, 5% colectomy rate at a year. So if you want to use cyclosporin, follow the bottom, IV, then oral, then azathioprine. And that'll get you best outcome. Key take-home point. At the very bottom, you can see all of the trials that I derived this literature from, or this slide from. At least 1 death or severe opportunistic infection reported per study. So you need to know what you're doing. You need to be responsive to those opportunistic severe infections. What did I do? So I knew the evidence. This is what I would do. I'd put them on cyclosporin. We use 2 milligrams per kilogram every 12 hours. For 7 days, we use trough levels at around 300. You've got to correct and follow magnesium, cholesterol. We place him on Septra for PCP prophylaxis. He's on his IV steroids. You can see the recipe, and we start using azathioprine around this time because we're planning for maintenance as an outpatient. Again, you'd expect with the cyclosporin response in 3 to 5 days. He's home for 3 months on oral cyclosporin, and he does well. Ultimately, he's on mesalamine and azathioprine indefinitely in his maintenance therapy. So this is what I would do if I was using cyclosporin. This is my recipe. You can also use infliximab, and there's a lot of data on this slide, but it looks similar to cyclosporin. Basically, using infliximab equals using cyclosporin from all of these trials. And at the bottom, at least one death or severe opportunistic infection reported per study. So it has the same sort of risk profile as cyclosporin. And you can see the individual colectomy rates getting down to about that 20% rate at 12 months in patients who failed outpatient steroids, came in with severe colitis, and now were failing IV steroids at day 3. I wanted to show you this trial recently published in Lancet. So this was a direct comparison. The last 2 slides were the individual studies. Here's a direct head-to-head comparison, infliximab versus cyclosporin. And you can see the take-home message. They're really both about the same. Both had a response rate of around 46% by 3 to 4 months. So again, use the drug you're comfortable with, cyclosporin or infliximab. I don't think it really matters. What about if you had used cyclosporin? Could you use infliximab afterwards? So here's a recent study published last year. 47 patients against corticosteroid-refractory came into hospital. IVs failed. They went on cyclosporin, and now that failed. So then within 6 days, they started infliximab. So this is heroic. And you can see the results. 35 patients by this time, if you had fallen out from colectomies, got a single dose of infliximab at time 0, just 1 dose. You can see that there was a fairly good response, but a third of them still went on to colectomy after that 1 dose. So there was a rapid fall-off. People are getting really sick. If you did get them, these people who partially responded and could give them more infliximab, then you were able to get a number of them better. So it is possible now to move from IV steroids that fail, use cyclosporin that fails, and add infliximab. And it is possible, but you're going to have a high colectomy rate. What did I do with this man? So we've moved away from cyclosporin. It's more complicated for us, and we're into infliximab. So we put him on infliximab 0, 2, and 6. He got his Septra. He continued his IV steroids for 7 days and then tapered to oral prednisone over 8 weeks. Again, we put him on azathioprine, and we had expected that he'd respond within about 3 to 5 days. So I'm going to sum up and tell you this is my algorithm. Let's work at it from the top going down. Severe ulcerative colitis, failing intravenous steroids at about day 3 to 5. That is the days that you need to be seeing improvement. And if you don't, you have 2 choices for medication. You can move on to colectomy, of course, but if you choose medication, you've got either infliximab or cyclosporin. Both are equal, as long as you know how to manage both of those drugs and control for the complications. Once you go on infliximab and cyclosporin, you have a surgical medical reassessment at, again, day 3 to 5. And if you're failing, I think you move on to colectomy. In some cases, as I showed you, you could go from cyclosporin and add infliximab. But most patients would end up with colectomy. And if you are responding, then you taper your steroids, start azathioprine and 5-ASA. This is going to be your maintenance therapy. You switch to oral cyclosporin for those 8 weeks, or you continue your infliximab every 8 weeks, depending upon which of those drugs you're on. So this is what happened to this man. And I just talked to him on email, actually yesterday, to find out how he was doing, because he's a real case. Infliximab, he responded within about 3 days. Prednisone was tapered over 8 weeks. We eventually stopped his rectal therapy. His infliximab required dose escalation after about 3 years. He was losing some response. And actually, he came back about 6 months ago and said he didn't want every 4-week infusions anymore. He was too busy. Would I de-escalate him? So we colonoscopy, reinvestigated him, no inflammatory markers, mucosal healing, so we de-escalated him to every 8 weeks. He's still on azathioprine and his mesalamine, and he remains asymptomatic. So thank you very much for your attention.
Thank you.